Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients with substance use issues and addictions. I'm your host, Dr. Kasey Claborn, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
Have you ever had a patient who you suspected had a substance use problem, but you weren't quite sure how to initiate the conversation? On this week's episode, we'll be talking about ways to screen for substance use and what to do when a patient has a substance use problem. Today, we are podcasting from Providence, Rhode Island with Dr. Sara Becker. Dr. Becker is a clinical researcher and licensed clinical psychologist dedicated to improving the utilization of effective behavioral treatments for individuals with substance use disorders. She is faculty at the Center for Alcohol and Addiction Studies at Brown University. She is also the project director of the New England Addiction Technology Transfer Center and the co-project director of the South Africa Addiction Technology Transfer Center. Welcome, Dr. Becker.
Hi, Dr. Claborn. Thank you so much for inviting me to participate in your podcast series. I'm really honored to be here today.
So tell us a little bit about your work.
Sure, I'd be happy to. I have two streams of clinical research interests. The first is that I'm really interested in trying to increase the utilization of those behavioral and pharmacological interventions that we know are effective and trying to promote their uptake in community-based treatment settings. This area of research is what's called as dissemination and implementation science.
Implementation science is the study of methods influencing the integration of evidence-based interventions into practice settings. Dissemination is the process of spreading knowledge and information to these settings. According to the University of Colorado School of Medicine, increasing the number of interventions that translate into practice can have a direct and positive impact on the public's health by increasing access to approaches that have been demonstrated to improve health in diverse populations.
The second area of research is really focused around trying to improve the quality of care for adolescents and young adults with substance use and addictive disorders.
Initiating conversations about substance use can be hard with patients, and we know that patients notoriously underreport their alcohol and drug use. What are some ways clinicians can talk about substance use with their patients, specifically ways to get an open and honest response?
That is such a great question, and it's something that when I'm out in the community training providers comes up a lot. One of the things that I find helpful is a framework in the medical field called the 5 A's. It was actually designed to help medical providers have a way of talking with their patients about cigarette use, but I think it's also really helpful to think about using this framework to speak with patients about alcohol and other drug use. Each of the 5 A's corresponds with a specific step that a medical provider can take to really open up a conversation with a patient around alcohol or drug use. The first A stands for ask, or in other words, to screen. This is the first A because it starts the process of gathering information from the patient about alcohol or drug use.
Screening is the process of evaluating a patient for the presence of a particular problem. The outcome will be a simple yes or no answer. There are many different types of screening methods, several of which will be discussed in this podcast.
One helpful strategy that I've found is that it's really important when you ask a patient about alcohol or drug use, not to simply ask, did they use? Because this sets up patients in a way that often puts them on the defensive and I think makes the patient feel as if there's a specific answer that you want to hear. Instead, it's really helpful to try to ask the question about how often a patient used alcohol or drug use, because when you frame a question that way, it implies that you expect the answer to be that the patient has used at some point. And I think it communicates a less stigmatizing and less judgmental interaction style, and it really sets you up for a more productive conversation with that patient.
So what I hear you saying, Dr. Becker, is that you're really trying to normalize substance use behavior with your patients. Is that correct?
Absolutely. And so part of that first A, the ask step, is really just to make this a common part of conversation where you're routinely asking the question and you're asking it in a non-judgmental way. The second A then stands for advise. And in this step, the medical provider can give clear, direct personal advice to the patient about the need to make a change, especially if it is clinically indicated. So if a patient does report high levels of alcohol or drug use, the provider could simply say, I'm concerned about your alcohol or drug use, and I would recommend that we work together to make a change. Now, one thing that's talked about a lot in the medical community is the concept of a warm handoff. And in this step, the goal isn't simply to give the patient a piece of paper, that tells them, I think you should go talk to the people on this list, but really to help facilitate that process, because we know that a warm handoff in which a provider is active and engaged really makes a big difference.
Warm handoff is a technique used during the transfer of a patient's care between two members of the healthcare team. A warm handoff is often conducted in person to ensure transparency and communication.
The third A stands for assess, and in this step, the provider is really trying to get a sense of how willing the patient is to change his or her behavior. To be honest, a helpful strategy here is simply to ask. You can ask a patient a simple question such as, on a scale from 1 to 10, how ready are you to change your alcohol or drug use right now? And that'll give you a sense as you move forward. The fourth A then stands for assist, and in this step, the medical provider takes an active role in helping the patient to make a change if he or she appears ready to do so. And then the fifth A stands for arrange, and in this step, the provider or someone on the provider's team helps the patient actively by referring that patient for further assessment and treatment if indicated, and really actively helps to set up follow-up appointments.
So, Dr. Becker, one thing that I hear all the time from clinicians is that, they know a patient has a substance use problem, but they really struggle to link them to care.
So that last A.
Yeah, exactly. Can you talk a little bit about the rates of being able to link patients to care?
Yeah, it's such an important question. And you're right that the rates of patients who actually meet criteria for substance use disorder and those who then actually get into treatment are really disparate. Obviously, screening is part of this issue, that a lot of these patients simply are undetected. And so screening is one of the first steps to trying to improve referral to treatment. You're right, though, that even when a provider is doing an excellent job screening, they might not be aware of referral options, which is why care coordination programs such as what iCare is trying to build are really so valuable.
Although referrals made through an app, such as iCare, are not a traditional warm handoff, they still provide the benefit of open and efficient communication between providers, ensuring care is both coordinated and compassionate.
How many people that have a substance use disorder actually get treatment?
Among those patients who meet full criteria for substance use disorder over the age of 26, on average about 12% will actually be linked to any substance use treatment at all.
12%?
And it's even lower among young adults between the ages of 18 to 25. In that cohort, it's only 7.2%. This is according to national data from the National Household Survey on Drug Use and Health from 2016. So this is really a recent and continuing phenomenon.
Great. One thing I also hear a lot of is that patients have a really hard time navigating the system. What are some methods to improve linking patients to those services and helping them to navigate those systems?
Well, I think we could have a whole other podcast just about integrated care and the value of having integration. And levels of integration can really vary. So, for a patient, sometimes it's simple if they go and both, say, substance use and HIV care or substance use and mental health are in the same facility. In the real world, a lot of times that's really difficult. So the next step is really just to have tightly linked or coordinated services between one agency and another. And one way to start is possibly for an agency to have a partner organization that it has partners referrals with, or to just have a coordinated network or ecosystem of providers that agree to refer to one another. And obviously, I think one of the big questions that iCare is trying to answer is if technology can help assist that process.
Excellent. So let's transition a little bit. Thinking back to the 5 A's, are there signs someone should be screened for a substance use disorder?
Well, I think the most important principle is that it's really important simply to screen and to screen routinely. What a lot of people may not realize is that practice guidelines for primary care providers are actually to screen for substance use at every preventative health visit beginning between the ages of 10 to 12. So really there's a push that this should be part of our primary healthcare system, and it should be something that's really permeating throughout the medical system, because we know that substance use is a major burden on the medical healthcare system. It burdens providers, it burdens the cost of the system, and a lot of times patients are presenting for issues that are really co-occurring with that substance use problem. Another thing I think to keep in mind is that screening can be done in various ways. A provider can screen using biological indicators, such as a urine screen, or they can screen via self-report.
So what are some evidence-based screening tools that exist for both alcohol and then other drugs?
Dr. Becker will discuss 3 psychometrically valid screening tools called the Audit, the Dudit, and the DAS-10. Psychometrically valid screening tools are defined as tools that demonstrate soundness when used in clinical trials and research, meaning they measure what they are designed to measure. These screening tools are used to determine if an individual has or is at risk for a substance use problem. These screening tools can be used in conjunction with each other and other validated substance use screening tools. Now back to Dr. Becker.
That's a great question. There's actually a number of psychometrically valid screening tools that are available to medical providers to assess alcohol and other drug use. Two really common ones that were both published by the World Health Organization are called the AUDIT and the DUDIT. AUDIT stands for the Alcohol Use Disorders Identification Test, and it was designed to provide a brief questionnaire that can screen for excessive drinking. It contains only 10 questions that each ask about the frequency and quantity of substance use, and it's meant to be easily scored so that providers can have a sense of the patient's risk and the necessary next steps. The DUDIT was designed as really a parallel tool for assessing harmful drug use, and it contains 11 questions about frequency and quantity of drug use that similarly can be scored very quickly by the provider. So those two are obviously very popular because they were developed by the World Health Organization, but it's important to note that there are a number of other common screening tools for substance use, and some of which I think are even more commonly used in routine practice. One such example is called the DAST-10, or the Drug Abuse Screening Test 10 item versions, which has only 10 yes or no questions. And because they're yes or no, they can be scored extremely quickly. And so that can also be a really nice way to screen. As I mentioned before, when you're asking a patient out loud, the recommendation is usually to ask about how often a patient used and not to ask a yes-no question. But in this case, for this brief measure that's completed, the yes-no questions have been found to be very effective when patients are able to complete the questionnaire privately.
So with a screening tool like you've just described, would you recommend that the patients fill these out, or that the clinician actually sit down and interview the patient and walk through these questions with them?
That's such a great question, and I think it really depends on the clinic workflow and who in the clinic is the point person identified as the person to administer these questionnaires. Now, some primary care practices will give patients questionnaires to complete on tablets or on paper, to be done in the waiting room just to ensure that it happens at every visit. I think it would usually ideally be the medical provider that interprets the tool and goes over the results with the patients. I mean, if the medical provider has time in the workflow, asking the questions out loud is really excellent for rapport building. But the reality is many medical providers are extremely busy, so having a patient self-administer is certainly better than not administering at all.
So once you do screen a patient, and let's say that patient screens positive for having a substance use problem, what do you do after that?
Yeah, it's $1 million question, right? I think part of it is being really comfortable with whichever screening tool you're using. So if you're using the AUDIT as an example, there will be specific risk categories that when you score the question, it will tell you this patient is at a low risk category, and ideally there's a very clear risk algorithm for what the next steps ought to be. And in fact, the ones we've talked about today, the AUDIT, the DUDIT, and the DAS-10 all have that type of scoreable algorithm where once you administer, it should give you very clear instructions on what comes next. To generalize across these measures, typically the next steps consist of one of 4 choices. One choice is if the patient has no recent history of substance use, is simply to give positive encouragement. A lot of patients with substance use problems or at risk of substance use problems don't get a lot of positive feedback in their lives. And so simply saying, great job, I noticed that you haven't used in the last few months. That's really wonderful. Keep up the good work. Can actually be really reinforcing for patients. A second option is if a patient has indicated some recent use, but it's considered to be low risk, is simply to provide brief advice. So to say, given that you're presenting here to this medical setting, say for HIV care, I would recommend that you try to abstain from further alcohol or drug use, but it's just being very direct and giving brief advice. The third option is to do what we would call a brief intervention. And typically within a medical setting, a brief intervention can be as brief as 5 to 10 minutes. And it's really the goal of that intervention is to try to increase the patient's motivation to change his or her behavior. And then the fourth option is giving a patient a brief intervention and then subsequently referring them for specialty care to address the substance use.
Great. Thank you so much, Dr. Becker, for sharing your expertise on this topic. This has been a Project iCare podcast with Dr. Kasey Claborn and special guest Dr. Sara Becker. If you liked our show and would like to learn more, check out our website at sites.utexas.edu. /Health Innovation Lab or find us on Facebook at UT Health Innovation Lab. Our website displays more information about Dr. Becker, as well as all the resources discussed today, and will be linked in the description below. Thanks again for listening, and stay tuned to hear Dr. Becker discuss her current research projects. I would love to hear a little bit more about some of the ongoing projects that you have.
Well, one project that's really relevant to some of the questions we've been talking about today is an initiative called IMSBIRT, and that stands for Implementing Alcohol Misuse Screening, Brief Intervention, and Referral to Treatment. And that's an initiative funded by the National Institute on Alcohol Abuse and Alcoholism. And it's a study where we're really trying to help 10 pediatric trauma centers across the country to integrate screening and brief intervention and referral to treatment into their routine care with injured patients. And the rationale for that study is that we know that youth, as with adults, often presenting to trauma centers are presenting because they've had an injury, and a lot of times that injury has to do with alcohol use. So either impaired driving, or a fall, or an accident. And we know that rates of alcohol use are very high in this population, but it often is not addressed. So we're going around the country and training these pediatric trauma centers on how to screen effectively, how to score that screening tool, and then give an appropriate brief intervention, and then give a referral to treatment, usually back to the primary care provider if indicated. It's a really exciting project, and we'll be continuing for the next 4 years.
Very cool.
For more information on SBIRT, or Screening, Brief Intervention, and Referral to Treatment, see the presentation linked in the info box or visit the Health Innovation Lab website.